Good afternoon, everyone. Thank you for joining us this week at our annual NHSN Training. I hope everyone had a good lunch. Thank you for all online viewers that are on right now. So let's begin. My name is Prachi Patel, and I am part of the Methods and Analytics team here at NHSN. In today's afternoon session, I will be covering how to analyze your device-associated data. By device-associated, I'll be referring to your central line-associated bloodstream infection and your catheter-associated urinary tract infections. So for today's objectives, what I hope you will walk away with, hopefully understand the standardized infection ratio and its use in the interpretation of device-associated data, discuss the risk adjustment methods for your device-associated SIR data, explain the use of the SIR data and the interpretation of the results, and finally, we'll review some frequently asked questions. So I'll be using a couple of scenarios to illustrate how to interpret your data. We want you to come away with a better understanding of how to use the risk-adjusted data and to relay this information to your staff or your hospital board. The more comfortable you are with your data, the more you'll be able to use your NHSN data to drive your infection control practices. So why should you analyze? Analysis tools within NHSN help facilitate internal validation and help ensure the accuracy of your data. Reports generated from NHSN can help inform prioritization and success of prevention activities within your facility. The data that you enter into NHSN may be used by CDC, CMS, your state health department, your corporation, or even special study groups. And remember, this is your data. You should know your data better than anyone else. And we will all be continuously saying this over and over and over again. The accuracy of your data is vital. And to check the accuracy of your data, you have to analyze. So here's a little review of the standardized infection ratio, or the SIR. The SIR is a summary statistics that compares the number of healthcare-associated infections, or HAIs, that were reported to the number of HAIs that were predicted to occur. This is based on a calculation using data for HAI events that occurred in a given referent time period. The SIR is the number of observed infections divided by the number of predicted infections. This measure is used to compare the HAI experience among one or more groups of patients to that of a standard population. So, for example, NHSN. And the SIR is then used in public reporting by CDC at a state and national level, or by CMS at a facility level on Hospital Compare. So the SIR can be used to assess a hospital's performance based on the national baseline data. An SIR of 1 would mean that the number of observed infections equals the number of predicted infections. So to put it another way, the infection rates in your facility or location is similar to the US baseline data with risk adjustments. If your facility, let's say, has a SIR over 1, that means your facility has more infections than what would be predicted for your facility after taking into account risk associated with that HAI, such as the size of your hospital or your teaching status or even the location type. For example, let's say your CLABSI SIR is 1.25. Then we would say that 25% more infections occurred than predicted. An SIR less than 1 would mean that your facility has fewer infections than what would be predicted. For example, let's say one of your locations has an SIR of 0.50. Then that would mean that 50% fewer infections occurred than what was predicted. So what's the basis for using your SIRs compared to your rates? So the SIR accounts for differences in incident and exposure across available factors known to be associated with device-associated data. The SIR allows users to summarize data by more than a single stratum. So it adjusts for differences in the incidence of infection among that strata. So for example, the HAI experiences of a hospital with a large burn unit cannot be directly compared to a facility without a burn unit, unless the difference in exposure and infections is taken into account. The SIR permits these kind of comparisons between the number of infections experienced by facility, group, or state to the number of infections that are predicted to have occurred based on the national data. So this accounts for risk factors in the calculation of the SIR to help promote comparisons that are more fair and valid. Now, calculating the number of predicted infections. This is done based on the 2015 National HAI aggregate data, and it's adjusted for each facility using variables that were found to be significant. For CLABSI, CAUTI, and NBI-LCBI, then a negative binomial regression model was used to calculate the number of predicted events. Today, we will be manually calculating the number predicted, but remember, NHSN does do those calculations for you. Also, I would highly recommend that you read the SIR guide, which is linked right down here below. This document provides a detailed look at information regarding the different statistical models for all of the HAI types, parameter estimates, and also some examples. So this slide displays the general negative binomial regression model for calculating the number predicted for the device-associated data. It has an alpha, which is the intercept of the model. Then it has a beta, which is the parameter estimates or the risk factors. The X value, which represents the presence or the absence of the risk factor. And then finally, the number of predictors. Once you have these values, you would complete the calculation and then take the exponent of that result. I know this looks intimidating. I can see by your faces. Everyone looks so overwhelmed. But please don't be intimidated. Remember, NHSN does these calculations for you, and we will walk through this model. So before we dive right into the model, let's take a look at the factors that are included in the device-associated model. This is for acute care hospitals. The risk factors included for CLABSI, CAUTI, total VAE are CDC location, facility type, medical school affiliation, and facility bed size. The only risk factor included for the CLABSI NICU model is birth weight. And the IVAC Plus model includes CDC location, medical school affiliation, and facility bed size. The variables such as medical school affiliation and facility bed size are pulled from the annual survey. And since many of you have probably just recently filled out your 2018 survey, you know where you can find that information. So let's work through the CLABSI model and calculate the number predicted. So the number of predicted infections, like I said, is calculated under the 2015 baseline, and it's risk adjusted based on the following variables that are found to be statistically significant predictors. The table on the slide and the table on the next slide shows all the parameter estimates for each of the predictors of the CLABSI model. The first table shows a breakdown of the different groupings of the CDC locations and their parameter estimates. The CDC location refers to how the units are mapped within NHSN according to the CDC definitions. This information depends on the patient population of the unit. Now, the second table includes the parameter estimates for medical school affiliation category, which is grouped into major, graduate, and undergraduate non-teaching, which is the referent value of just this category. Then by facility type, the first group being if the facility is a children's, military, veteran affairs, women, children's, and the second grouping for facility type, which is general acute care, oncology, orthopedic, psychiatric, and surgical facilities. This is the referent for this category. And lastly, the category for facility bed size is divided into three groups. Greater than or equal to 224 beds, then 94 to 223 beds, and less than or equal to 93 beds, which is the referent for this category. These variables in the table and from the previous slide fill in the values for that equation that was shown initially. This will fill the alpha, which is the number up top that says negative 7.6325, then the beta value, which would be the parameter estimates, such as the different categories for your CDC location or your facility type, and the X value, which would represent the presence or the absence of the risk factor. So I know this slide looks very overwhelming. There's a lot of tiny writing everywhere, but let's look at it piece by piece. To the left is a negative binomial regression model with all the parameter estimates. to the right is both the tables combined into one. The intercept comes from the top section of the table. Then the CDC locations would come from this section. The medical school affiliation from that middle section. Right below that would be the facility type, and below that is the facility bed size. The arrow shows where each parameter estimate comes from when entering the model for calculating the number predicted. One thing that I do want to point out are the reference values are not included in the model. And then finally, remember the device days, which are used as the final multiplier once you have calculated the exponent value. I always receive questions, how are device days incorporated into the model? How are they being used? And they're being included at the bottom as a multiplier. Once you've done the entire calculation and you've gotten the exponent, you would multiply it by your number of device days. So a detailed list of the CDC locations are included in each category can be found in the SIR guide. So let's walk through an example of calculating the number of predicted for a CLABSI, for the CLABSI HAI type. This is an acute care facility with 215 beds. It's a general acute care hospital. It's a graduate teaching facility. It's reporting for a medical cardiac critical care unit. And for the month of January 2019, it has 565 central lines. So for most of the variables shown in the parentheses in the equation above, you would replace the variable name and therefore multiply each parameter estimate with a 1 or 0, depending on if the factor is present for the facility. Yes would be a 1, no would be a 0. So this facility is reporting for a medical cardiac critical care unit. According to the SIR guide, this unit is located within the adult critical care unit group within the location category. So you would add 1 to this grouping. This table on the right, like I said, is from the SIR guide. Since this is a graduate teaching facility, we would add 1 for the variable that corresponds to the medical school affiliation is equal to graduate. And this is a 251 bed facility, so you would replace this variable with a 1. I would like to point out that since this is an acute care facility, this facility falls into the reference category, which means it won't be in the model. So now that we have the variables in our equation, we can now use our calculators to calculate the number predicted. You can use your phones also by switching it to a scientific view. Add up the present variables and take the exponent of that total. Once you have that value, make sure to multiply it by the central line days. So for the month of January, we had 565 central line days. So you would multiply that by the exponent once you've done all these calculations, and that would be equal to 0.494 for the month of January. That would be your number predicted. Here's our first poll everywhere question. So your hospital has been measuring CLABSIs using the SIRs, and you've noticed a difference in your number predicted from month to month. Primarily, what factor would largely contribute to the variations in the number predicted from month to month? What do you feel like would be the reason for that? And I'm not showing the results, so you guys can't see what everyone else is putting in. I'll give you guys 30 more seconds. Yes. Yeah, they're moved around because there's a different poll that was put in. That's why, but it's the same choices, is it not? But they're just in different order, correct? Yeah. Yeah, just please use these. I'm not sure it was in. You can go back and change it. You can go back and change your answer. Yeah. And that is correct. It is central line days. So let's work through why it wouldn't be the other selections. So your CDC location rarely changes. It's dependent on what you've mapped your location as. So if there's a change in your patient population, that would be when you would change your CDC location. Your facility bed size, if there are any changes, it would be per year, which would be in your annual survey. Your facility type is what you enrolled your facility as. So there won't be any drastic changes to that unless there's been a complete change in your facility. Your medical school affiliation works the same as your facility bed size. If there's any changes, they would be by year. But remember, your central line days are the multiplier that changes every month. So that really shows the difference month to month, what you're seeing. So let's move on to the SIR tables in NHSN. Before running any reports in NHSN, please be sure to generate your data sets. And that's because as you make additions and changes to your data, you have to generate your data sets to make sure those modifications are incorporated into your reports. This process is user specific, so if you were to generate your data sets, that doesn't mean that your coworkers' data sets will be generated also. The default setting for generating your data sets will only include the last 3 years. Recently, I've been receiving a lot of emails about why 2015 data is not in your reports, and that is most probably because it's on the last 3 years, so it would only go up to 2016. However, if you would like to see your retrospective data, you can click that box, that checkbox right there that says include all data reported, and it will include all your retrospective data into your reports. So now that we are aware of how to calculate your number predicted, let's look at the different reports that are available in NHSN for looking at this data in your reports. So as you can see by this slide, there's multiple locations for your device-associated data. As you navigate in the analysis reports, the device-associated module will include reports for CLABSI, COUTI, and VAE. The data included in this specific module will be data from all locations that have reported data within your facility. The next place you can find your device-associated data is the CMS reports. These reports are important for checking your data that will be sent to CMS on behalf of your facility. Data included in these reports will only be from in-plan data from select CMS reportable locations. Not all your locations will be in these reports, and we'll go over that later on. Lastly, the baseline set 1 folder will include data up to 2016. Before we take a look at the CLABSI SIR table, I just want to point out the different options that are included in the device-associated module folder. You have the option to run a line list, a frequency table, bar and pie charts, rate tables, and your SIR tables. Each report provides a unique way of visualizing your data. And moving on to the CLABSI SIR report, this specific report can be found by looking in the device-associated module under central line associated BSI. When you click on the report, there will be 3 options. The first option would be to run the report, which means the report will run with default modifications already in place. The second option would be to modify, and this is where you will have the opportunity to change the report to your specific modifications. And the last option is to export the data set. The option for exporting from here, from this screen specifically, will export the raw data set without any modifications or SIR calculations. So for the next couple of slides, we'll discuss the modification and take a look at your report. So we want to look at the SIR table for CLABSI surveillance that occurred in all critical care locations in 2018, grouped by half, so 6-year increments. We initially start the process by limiting the time period by including summary year 2018, as you can see. You have the option to adjust this date variable by summary year half, summary year month, or quarter. Like Scott said, the show descriptive variable names box is extremely helpful for if you're trying to present your NHSN data to people that are not aware of how NHSN variables work or what they mean. So if you have numpred, you all that work with NHSN on a daily basis know what that means. But if you're presenting to people that don't, it's helpful to have it spelled out and say number predicted. Next, we want to filter to just critical care units. So you would go to your filters tab and add in location type equal to CC. Filters is usually where a bulk of your modifications will take place. And lastly, since we want to display our table by 6-month increments, you would put in your display options group by summer, year, half. So now here's our table with all of our modifications. Before we begin breaking this table down, I just want to mention that all the data from this presentation is fabricated data, and it's not anybody's real hospital level data. At the top of the table, you could see the report name, the baseline information in the table type, and right below that, you can see the filters that were applied to the report. So it says if location type equal to CC. It's helpful, let's say when you're running your CMS reports and you have a question about what's being included in those reports, you can find that information right there. It says what locations are being included in the reports. As you can see, the table is separated by two half-year options with the columns for your org ID, CCN, the time, the different SIR calculations, and your p-value and 95% confidence interval. Also, I just want to point out another important factor of this table is the footnotes. Please take the time to always read your footnotes. There are certain important information in there. So for example, the SIR cannot be calculated if your number predicted is less than 1. Also, for the CLABSI tables, it provides exclusions that are in place for your CLABSI numerators, such as ECMO and BAD. So certain important information, things that are included in the model are also in the footnotes. And at the bottom is the source of the aggregate data and when was the last time you generated your data sets. So if you're looking at the report and you feel that your central line data count is off, or your number predicted, or even your infection count is not what you remember putting in, if you look at the bottom, you'll be able to see when's the last time you generated your data sets. Now let's take a detailed look at your SIR table and interpret the table. There is a small change in this slide compared to what you have in your booklets. It's in the second bullet. So this facility reported 6 central line associated BSI, or your infection counts, in critical care locations during the first half of 2018. This is the observed number of CLABSIs. The overall SIR for this facility during the time period is 3.498, indicating that the facility observed more infections than what was predicted. The number of CLABSIs predicted to occur for the first half of 2018 was 1.715, and for the second half, 1.432. One important reminder, even though this is not the case, like we've mentioned, if your number predicted is less than 1, then SIR will not be calculated. So let's go on for more information regarding the p-value and the 95% confidence interval. The p-value is a statistical measure that tells you if the observed number of infections is significantly different from what was predicted. So if your p-value is less than 0.05, that indicates that the number of observed CLABSIs, or your infection count, is significantly different, either higher or lower from what was predicted. In this example, the p-value for the first 6 months is less than 0.05. And this would say that there is a significant difference between the number of infections observed and the number of infections that were predicted. The 95% confidence interval is the range of values in which the true SIR is thought to lie. If the confidence interval includes the value of 1, then the SIR is not significant, which means that the number of observed infections is not significantly different from the number of predicted, using the same convenient cut point. So if the lower bound is less than or equal to 1 and the upper bound is greater than or equal to 1, then the SIR is not significant. For this example, the value of 1 is not included in the interval, which means that the number of observed infections is significantly different from what was predicted. Let's look at this in a graphical form. The lines in red represent the confidence intervals that include the value of 1, which makes them not statistically significant. However, the lines in green that exclude the value of 1 are statistically significant. So here's another poll everywhere question. An SIR will be calculated as long as the number of predicted infections is greater than 0.05. A couple more seconds. That's right. False. The SIR will only be calculated if the number of predicted infections is greater than 1. So this rule was instituted to avoid the calculation and interpretation of statistically imprecise SIRs, which typically have extreme values. So now that we know how to interpret your SIR tables, let's look at the actual report. When you run the report in NHSN, it will be separated into 5 tables. The first table will be the overall SIR for the facility. The second table will be the SIR by location type. The third table will be by CDC location. The fourth by individual locations. And the fifth or potentially sixth table could be data not included in the SIR. So the first table includes this. So we're looking at the catheter-associated UTI tables, which are similar to CLABSI. And this is for the acute care device-associated module. This is not your CMS reports. This table will include all the units for which your hospital reported data during that time period. For this example, I used the cumulative display option during the report modification. And if you don't change your group by function, it will automatically show 6-month or year-half results. So the second table within the output will produce an SIR for each location type. This specific report on the slides has CC, which will be inclusive for all critical care units, CC Onc, which would be oncology critical care units, other would be your non-acute, ward would include all your medical ward or surgical ward, any unit that's mapped as a ward. And lastly, ward onc, which would be your oncology wards. Now this table produces an SIR for each CDC location that has reported county data. CDC locations are standardized location definitions as identified by NHSN. And lastly, this table produces an SIR for each individual location. So this is how you have entered this location with your specific identifier. And lastly, the 1 to 2 potential tables that could be produced list the locations that are not included in the SIR. And this could be due to missing data, or they may be outpatient locations. Now, let's move on to rate tables. The rate tables provide, for this specific example, the county count for a location, the number of catheter days, the rate, the number of patient days, and device utilization. This report is a great resource for any routine data quality checks that you may be performing. It provides a quick overview of your data at a unit level. I know earlier on there was a question about if you wanted to verify your device days. Well, a rate table would be a good option to check that. Also, as you all may be aware, pool means will no longer appear in your default device-associated rate tables for 2015 data and forward. You now have the option to run SURs, or standardized utilization ratios, for device-associated data. My colleague Agasha will be covering SURs in her presentation later on this week, so stay tuned for that. information regarding the analysis option. So another way you can use an analysis report that may be useful to you and your facility is the statistics calculator. The statistics calculator can be used for customized SIR analysis. Let's say you would like to compare your unit data to the value of 1. You would select that specific report, input that required information, and the table that would be generated can provide additional statistical evidence like your p-value or 95% confidence interval. You even have the option to compare two SIRs. As you can see, there's multiple different options in the calculator that can be used for comparisons. Now let's move on to some FAQs that we receive in the NHSN mailbox pertaining to device-associated data. So NHSN, when I'm running my device-associated SIR reports, I'm unable to find a CLABSI that was entered in February 2019. Before you ask, I generated my datasets. It should be in there. I'm missing a CLABSI from my medical ward, and it appears in our line list, but it's not in any of the SIR reports. So can you tell me why? So before answering the questions, the first thing we would troubleshoot was, have there been any protocol changes for why certain events may be excluded from the CLABSI calculation? And as you all may be aware, ECMO, VAD, and MBI LCBI events, CLABSI events, are not included in the CLABSI numerator. So I am modifying my CLABSI line list to incorporate those additional variables to see if this specific event meets any of those criteria. And as you can see in the box outlined in blue, this specific event for February was an MBI LCBI. And since it was an MBI LCBI, it will not be in your CLABSI report. It will be in your MBI LCBI report. So here's a look at your MBI LCBI options in NHSN. The report options are very similar to the CLABSI report options. There are options for line lists, frequency tables, chart types, rate tables, and SIR. To the right is an example of the SIR table. And as you can see, the reports very much mirror the CLABSI reports. Here's another question. NHSN, when running my CMS IQR SIR report, I'm unable to find a county that was entered in January 2019. My datasets have been generated. I'm missing a county that appears in our device-associated county SIR reports, but it's not in my IQR SIR report. Why is this event not being included? So specifically for county, there are no numerator exclusions that I needed to look up for the protocol, so that would exclude this event. However, like I mentioned earlier, CMS reports include data from specific units. Keeping this in mind, I modified the line list to include the loc CDC or CDC location variable. As you can see, this event occurred in a telemetry ward. Telemetry units are not included in the data sent to CMS for CLABSI and county. Now, why is this? Why are they not included? Well, that's because there are specific units that are reportable per the CMS program. For CLABSI and county, here are the reportable locations. For CLABSI, it's adult, pediatric, and neonatal ICUs, and adult, pediatric, medical surgical wards. For county, it's adult and pediatric ICUs, and adult and pediatric medical surgical wards. So your acute, your mixed acuity wards, your telemetry wards, they won't be included in your IQR reports. So we also get a lot of questions about why their SIR and their number of predicted infections change from one week to another. Some of these changes that can impact your SIR and number predicted are either the entry or deletion of events, changes to number of patient days, device days, or admissions, the removal or addition of a monthly reporting plan, changes in the relevant factors included in your models, such as the medical school affiliation, facility bed size, and also the resolution of your report no events alert. It's extremely important that you resolve the report no events alert. And the reason for this is if you do not indicate that your facility did not have any events for a specific month, that month of data will be omitted from your SIR reports. This directly impacts your CMS data. These omitted months will not be included in your SIR reports or the data sent to CMS. So it's really important that you resolve your alerts before any CMS deadline. So in summary, this is your data. Know what your data says about your facility. Understand the data that you derive from your analytic results. Understand how you can customize these reports in NHSN to give you the data that you need. And remember, data from your facility can help drive prevention measures and reduce HAI burden. So this is the end of my presentation. I would like to thank you all for listening to me, and I would like to thank you for all your prevention efforts that you do day to day. Thank you so much. I will take questions.
So I think I understand the ones and zeros portion of the formula, and that the
Good job.
last step is to multiply by the device days.
Yes.
But those middle steps, can you go over those one more time?
The actual model?
Yes, please.
And I would be happy to work with you through this on the side if you wanted to work through it. Yeah.
Sounds good.
These slides?
Yes, so the steps after this and before you multiply by the device days, what are those again?
So I think it'd be easier if we came to the side and we worked through it.
Okay,
So if anybody
that's fine.
else is interested in that, I will be here to the side and we can look through it. Yeah.
Thank you.
Yeah.
Hi, thank you for the very nice presentation. My name is Onofre Donceras from Cook County Hospital in Chicago. I noticed that the CDI SIR is calculated quarterly. I understanding it correctly? Because when I query, see if I have a cluster of CDIF, I would like to see a month-to-month SIR. But every time I query it, it only gives me the quarterly result.
I know that's a great CDI question that we receive all the time. And our CDI SME, she will be presenting later on this week and she'll have answered that question. But yes, they can only be run quarterly, not at a monthly level. And she'll go over why that is the case.
Thank you.
Is there a way to find your whole hospital CLABSI rate or CAUTI rate if you have a separate rehab unit with a separate CCN number? If can you generate it by the hospital and that together or not? Or do you have to keep them separate?
You do have to keep them separate because there's a different model involved to calculating that information. So it doesn't work the same way if you were doing it for your acute care hospital and if you're doing it for your rehab location. So
Okay.
they're both generated differently and they won't come up in one table also.
Thank you.
So my question is relative to the differences between the benchmark that is set by Health and Human Services versus the CMS benchmarks. So I understand the differences in the variables and how it's calculated, but
Are you talking about the HHS goal?
Yes.
Okay, it's a great question. We're going to be having a TAP presentation and that will be covered there, but continue with your question. Yeah.
Well, then I'll wait till the end.
Because I don't have that much information about it, and our
Okay.
SME for TAP will have that information, be better able to answer your question. Yeah.
It's just that the variables that affect that goal is what makes it different. That's the basic question
Okay.
in the SIR. So when you generate the SIR using your whole house data without any exclusion criteria versus the CMS, it's that exclusion criteria that
Right.
creates the difference in the SIRs.
Right.
Okay.
Yeah. And that's a great question, and we can speak about that on the side. Yeah.
Thanks.
Hi, Anne Marie Flood, City of Hope, Duarte, California. And I wanted to ask, because I appreciate that in this latest I don't know what happened with my voice now. Excuse me. In the latest SIR model that we have pulled the HCT units out of the general oncology pool. I wanted to ask what the thoughts would be about looking at the leukemia lymphoma group and pulling that out as well as a separate higher risk than a general surgical oncology or medical oncology. Because at least in my patient population, we can have patients who still are on profound and prolonged neutropenia because they're relapsed or they are on a study criterias and the like. And so they do have a different risk than, let's say, a general solid organ oncology unit.
Right.
So I know when the original SIRS came out, all oncology was in one pool with a separation out for peds, hematology. And this latest one I just saw, I was gratified to see that they pulled out the stem cell, the transplant group, but still lymphomas are loaded into the rest of the oncology groups. And I really would state that those are not the same risks.
Right.
And when we are in a publicly reported situation, such as in California, and I do 800 stem cell transplants a year in a 215-bed hospital, I have a slightly different risk group than let's say an acute, a med-surg hospital or a community practice. And it's not as easily reflected when you do roll-up SIRS for the institution. And that's just my comment.
Okay. Thank you. Just go ahead.
Oh, I was just going to make a comment to that regarding the leukemia and lymphoma units, and certainly we are interested, especially in the future when we look at updating risk models. But we can only use the data that we have available, and there are some locations and patient populations that are so few having data reported that we don't have enough data in which to find significance and to keep it different as a risk factor. And that happened to be the case with leukemia and lymphoma units. I don't even know if we had a dozen of those units that had been reporting during that time period. So certainly we would encourage hospitals, if you have the ability to do so and are interested in reporting more data to NHSN and contributing to that, that would definitely help move those models forward in the future.
Thank you so much.